Like, first of all, we have to study about the renal system. Renal system is a very easy thing that we have been discussing about from the 2 or 3 years, from the very beginning of the medical studies. We have been studying about the renal system, but actually still the students don't understand about the renal system, how the renal or the kidney physiology is, or what the pharmacology is, or what the pathology is. So today we are starting a series of lecture on the renal system, the whole complete stuff about the renal system, from the very start of the renal, like the embryology, before the birth, how it happens, like how the kidneys are formed firstly, then we will go through the growing of the kidneys, and then we will go through the normal structure of the kidney, then we will go the normal processing of the kidney. So first of all, today what the topic in this lecture, what we will be discussing about is the renal embryology. Embryology is a very interesting subject which we have been discussing, and we have been done with the embryology, but still we are going through a little recap of the renal embryology or nephrogenesis. So nephrogenesis means the formation of the nephron. So formation of the nephron is a thing, and renal embryology is a thing. That formation of the kidney is a thing, and in between the kidneys there is a formation of the nephrons. So how it forms, what are the circumstances and which week, or what is the time duration in which renal system is formed, we will discuss through about that. So before going to start this lecture, I want you to concentrate on the very beginning of the lecture, so that at the end of the lecture, like 5 to 10 lectures of the renal system, you would have the command, or you have the firm belief that you have done with the renal system. So done with the literal words, now the practical things, that renal embryology. Renal means the kidney, and embryology means that in the uterus, like within the, what happens with the embryo. So first of all, let me tell you about that very start, how the fertilization happens or how the implantation happens. So if you don't know about that, you cannot know about the renal embryology. So what happens is, for example, think about that this is the uterus, and here we have got the cervix, and we have got the vagina. Here we have got the fimbrias, and here we also have got the fimbrias. Here we will get our ovaries, and it might be not like the exact anatomical diagram, but still for the sake of the purpose of understanding, we are learning. So what happens is that during the cycle starts when the menstruation cycle is the first day of the menstruation cycle. So ovulation, when does the ovulation happen? So ovulation is the day when there is the maximum capacity of gaining the sperms to that of the fallopian tube, to that of the uterus, to that of the mating with that of the egg, so that a new life can form, or new life can exist in the world. So here what happens is, from here the sperm goes. So at the 14th day, before the 14th day of the normal menstruation cycle, which is the day of the ovulation. So what we can say, for example, that you have the cycle of the 28 days. First I will describe about the ovulatory day, and then we will go through the little discussion about that. So let's move it. For example, you have got the 28th day of the menstruation cycle. So how will you determine that what is the day of ovulation? You might be knowing in the previous lectures that from that exact period you have to minus that 14 days, or you can say the 2 weeks. So what you will get, this would be the ovulatory day. So what it would be, this would be the 14th day. It could be it depends on, it varies from the women to women, from the girl to girl, that it could be 28th, it could be 31st, it could be 26th day. So whatever is the day, you have to minus that 14 days or the 2 weeks. So what happens that if it is less than 28 days, then this is also a pathological condition. If it is more than 31 days, then this is also a pathological condition, which we will discuss in the fertilization lecture. But here what the under discussion topic is that you have to if you have to fertilize your egg, so on the 14th day you have to no, not on the 14th day. Here in this example, on the 14th day you have to give the sperms to that of the fallopian tube, so that they can mate with that of the egg, and afterwards they will give rise to the birth. So on this day, what happens that the cervix might open a little rather than the other days. In this day, the mucus would be thin like the female vaginal secretions will be thin. Why would that be thin? So that they can allow the sperms to go through the cervix. So in these days there would be the thin mucus. So that body temperature rises, and there are so many conditions so that you can get to know about the ovulatory day. When once the sperm arrives the vagina, and afterwards if it arrives the cervix, what happens? There are 4 billion nephrons, 4 billion sperms which are present in the female vagina. Some of them are spontaneously discharged, and what happens is that the other remaining would be 3 or 3.5 or the 3 million sperms, they would go to the cervix, they would go to the the uterus. And still there, vaginal pH, what it does is it destroys the sperms, because the vaginal pH is low, which is the acidic condition, and the sperm is the basic, so that it cannot that much survive. So partly it will die, and the healthy sperms which will luckily will not be destroyed by the vagina, they will go through and they will reach up to that of the uterus. So luckily they have got the chance to approach that of the uterus. So once they have approach the uterus, still there are the conditions that some of the sperms will remain in the uterus, and some of the sperms, what they will do, they will follow the endometrial contractions and endometrial lining. So they will float and glide on that to go through the fallopian tube. So some of the sperms will go to the one of the fallopian tube, and others will go to the other fallopian tube. So how can you think that which of the fallopian tube will have that of the egg? So there is a question, but still we can say that half of them will go to the right side and half of them will go to the left side. So what happens is that wherever the egg is present, they have to approach. The sperms will approach. So what will does is that, for example, here we have got an egg that was released by the.
So there are 2 ovaries, then how only one egg that maturation?
Okay, here the question arises that how only one egg. So it is a physiological condition that every month from one side there would be one egg, and from another side there would be from the left side. For example, this month you have got an egg from one ovary, and from the next month you will get the egg from the other ovary. So this depends, like if they will get the sperm in this month, like you will get the egg from the right side of the ovary. It's not fixed, like from one month there is from this side, and the other month there is from this side. Whatever it happens from any of the ovary, you get the egg. The main purpose is to fertilize.
Is it possible like 2 eggs?
It happens it happens in the zygotic twins. Like we have got the dizygotic twins, and we have got the the other twins which are the parental twins. But in this, what happens is sometimes 2 sperms fertilize 1 ovum, and sometimes 2 ovum are fertilized by the 1 sperm. So this is a long story that we will further discuss on the time of the fertilization. So coming back to our renal topic, what we are saying that here on the ovulatory day you will release the egg, and when you will release the egg, the sperms knows that you have to approach that. Then it will go over there, and afterwards the sperm will come, how the ovary releases. They are fibrous, so they are constantly doing in a brush like manner. They are moving around, and once they get the ovum and once they get the egg, they will catch it and then they will take it. So that the time when the fibria get it, the sperms also approaches over there and they have to meet over there and give a new kind of the birth. So at the first day, for example, the sperm comes here and like egg is present over there. So you must have to know that egg is a very large thing. Like egg is, as compared to the sperm is a very minute thing and egg is a very large thing. So then you can say that the head of the sperm, luckily some of the sperms will approach the egg. Then you have got the zona radiata, the first layer outside that of the egg, which is the zona radiata. For example, this is the egg, so you have got the zona radiata. So the sperms will come over here and they will act as the thing to just penetrate. They want to penetrate that layer. So once they have penetrated, some of the sperms penetrate like 2, 3, or it depends that how many sperms come between these 2 days in this era. What is happening in between? So this is the thing which is forming by day by day by day. You are progressing. Every day has been forming a new thing for a new, like, so they in these 9 months are very crucial. Every day there is formation of anything. There is formation of new thing, a new thing, and a new thing. So these days are also very important for the formation of the renal system. So here we get to know that there are the 3 layers, which is the mesoderm, endoderm and ectoderm. So ectoderm is outside, endoderm is inside, mesoderm is in between. Renal system is formed from the mesoderm. For once and all, clear it that mesoderm is formed, renal system is formed from the mesoderm. Mesoderm by itself has 3 types. You see here this point very close to this circular structure, which we call as the notochord. So what it is? It is notochord. This is the notochord. This is the paraaxial mesoderm, very close to the notochord. Then we have got the intermediate mesoderm. These are 3 types of the mesoderm, which is according to the presence of the closeness to the notochord. Then the third is the lateral one. So these 3 are very important, very crucial. And what important structures they are forming, we are going to discuss this. So intermediate mesoderm is the one which forms the urogenital structure. Urogenital structure is formed by the intermediate mesoderm. Uro means urinary and genital means genitalia. So urogenital structures are formed by the intermediate. So we have been discussing about the renal thing. The whole discussion, the whole speaking lecture which I have been giving is about this thing, urogenital system. Urogenital system, urinary and genitalia, which are the reproductive parts and the stuff like that, But here, the topic we are discussing is about the only means urinary, about relation with that of the urine or the urinary structures. Genitalia we will discuss into the system of the reproductive system. Here, intermediate filament and intermediate mesoderm will form that of the renal system. Also, the other stuffs which are also formed by the intermediate mesoderm are the gonads, but not the They will form the genitals but not gonads. Then adrenal glands. You see? Adrenal glands are also formed by the intermediate mesoderm. Also the vagina uterus is formed by the vagina uterus and penetrate over there. You see, so acromere would be supplying the energy to penetrate. Okay, so there would be the ATP formation, there the mitochondria in the neck of the sperms and the stomas, the stuff like that. But we will not go into that much detail. So there is an other layer. Say that these are the kidneys, and in the lower part they are attached. You see, they have to be distinguished. They must have to be differentiated, but they could not, and they are attached at a point. And the golden thing for the inferior mesenteric artery is that in behind the inferior mesenteric artery, it got trapped, and it could not ascend upwards. Now, by now it cannot ascend. If it gets trapped here, how can you retrograde these kidneys upwards? You cannot take these kidneys upwards. So due to the inferior mesenteric artery, they got trapped, they will remain in the pelvic region, then they would not descend upwards. So this will lead to the horseshoe kidney. What is the clinical presentation? That the kid will come, its kidney will be functioning properly. But what will be the disease? That some kind of the you can see hydroamnions. Hydroamnions would be presenting over there. Along with that, this is associated with the hydroamnions, and with the height of the hydroamnions, this can lead due to the reasons that there is the utropelvic obstruction. Utropelvic obstruction means that here is the kidney, here would be the ureter, and here would be the calyx and the pelvic region. But there would be obstruction over here. Utropelvic obstruction. It will lead to the hydroamnions. Hydroamnions means that the water is that the more water is present in that of the urine. And in the utropelvic obstruction, this is one cause. This can also lead to the renal failure. If it is developed, and if you are not treating it properly, and you are not done the kind of the surgery, so it can lead to that of the renal stones, or it can lead to the renal not the dysgenesis, but the renal improper functioning. So this was one thing which was due to a reason that there is the inferior mesenteric artery obstruction. Like it was a hurdle in between the proper ascending of the kidneys. This was one disease. The next disease is tubes, and which is the gonads, all over present over there, but not the gametes. Gametes are something which are formed in the later fetal development. But here in the intermediate mesoderm, you cannot say that the gonads are formed and also the gametes are formed. Only gonads are formed, not the gametes are formed. So this is the thing formed by the intermediate mesoderm, which is our point of concern. But next, before going into the further details, we have to discuss about the lateral mesoderm. So lateral mesoderm gives us the two branches, like two types of the mesoderms, which are, we can say, the splanchnic mesoderm and the somatic mesoderm. These both mesoderms are very important because the basic structures, very important structures, are formed by these mesoderms. So by the splanchnic mesoderms, we can say the visceral organs, like the visceral pleura or the visceral pericardium, or the sacs which are present in different organs, around the different organs, we can say they are formed by the splanchnic mesoderm. So visceral organs, visceral could be the pericardium. Pericardium, it means that around the heart. For example, this is the heart, and here goes the aorta, and the stuff like that. So heart is formed by the myocardium. Okay, there is the myocardium, there is different kinds of cells and formed together. We will discuss it into the further lectures. But here the point of discussion is that the pericardium, pericardium is the sac present around that of the heart. So this layer which is closer to the organ, this is the visceral layer. So visceral layer is formed by the splanchnic mesoderm, and the parietal one is not formed. This is the parietal one which is away from that of the specific organ. So in the pericardium, the visceral pericardium, this one which is attached to that of the organ, is formed by the splanchnic mesoderm. You got my point, what I am trying to say. Secondly, for example, if we talk about the pleura. Pleura is present around the lungs. So these days pleura is present in the around the lungs. Okay, you can say that around the lungs, here it is present, the pleura. So this visceral one is formed by the splanchnic mesoderm, okay, but the parietal one, this is the parietal one which is away from that of the organ, is not formed by the splanchnic, is formed by the somatic mesoderm, okay. This is one thing. Now the peritoneum, also the same way peritoneum, in the abdominal region, it also has the visceral layer in the parietal layer. So visceral layer is formed by the splanchnic mesoderm, and the parietal layer is formed by the somatic. Along with these three things, which is the visceral layers, there is the the major blood vessels. I can write it here. So major blood vessels are formed by the splanchnic mesoderm. Even the lining of the gut is formed by the splanchnic mesoderm. And also the respiratory tract, the respiratory tract, we have got the in the nostrils, then we have got the respiratory tract, lower respiratory tract, there is the trachea, there is the bronchioles, there is the the alveoli, there is the alveolar sacs and stuff like that. So whole of that thing, that the respiratory tract is formed by the this splanchnic mesoderm. So it is an important thing. Then mesenteries are also formed by the splanchnic mesoderms, and along with that of the myocardium, which is also formed by the splanchnic mesoderm. So this was just about minor details of the mesoderm, so that you can get to know what we are trying to study. This is not related with that of the lecture, but just I wanted you to clear what are the mesoderms. We are very confused in every lecture of the embryology, that what are these three layers and how the different organs in our body are formed. So the blood vessels lining of the gut, respiratory tract, myocardium, and also along with that there is the epicardium formed by the splanchnic mesoderm. Somatic mesoderm is another type of the lateral mesoderm which is present at the lateral side of this specific structure, which forms specific organs, and the organs which include the parietal layers. Like I've already told you about the three important layers, which is the pericardium, pleura, and the peritoneum. So this is formed by the somatic mesoderm. Now it comes to the paraxial mesoderm. Paraxial mesoderm we've already talked about, but still we are going to recap a little bit, that the axial skeleton is formed by the axial skeleton is formed by the parietal mesoderm. Along with that, the dermis of your skin is also formed by the paraxial mesoderm. But here we say that the axial skeleton is formed by the paraxial mesoderm. What about the appendicular skeleton? Appendicular skeleton will be formed by the somatic mesoderm. So this is the whole summary which we were discussing about the embryology of the very the fetal development. It starts from the here, like like this, when the sperms goes and the egg mate, and in the fallopian tube it goes, and in the first day, 0 day, which is the ovulatory day, it will form the zygote, and after zygote it will form the morula, and afterward it will form the like early blastocyst, then the late blastocyst, and there would be the 8 cell stage, there would be 16 cell stage, and after that there would be the implantation at the 8th to 9th day. It depends that on which day it is ovulated, so it depends upon that. So afterwards it will form, it will be implanted over there, and after implantation the whole thing starts over there. So but the important thing which renal development has to be discussed is that in the 4th week there is the development, there is the start of the development of the renal system, or we can say the like not the proper kidneys but the false kidneys, we can say. How they are developed, let us discuss about that. There is here, for example, here we have got the amnion. Amnion, we have got the omphalloamnion, and then we have, okay, solitary unilateral agenesis, or the bilateral agenesis, then is the Potter syndrome. So these are all things which are present, and that of the congenital defects of the embryo, or we can say during that of the fetal life, so the baby has to suffer in the whole further life. First we will go through the easiest one, which is the horseshoe kidney. So how the horseshoe kidney would be presenting, what do you think about that? Have you ever heard the term horseshoe? So horseshoe is just like the horseshoe actually. It would be this one, by this way or this way. So how can you clinically relate the horseshoe kidney with this disease? We can say that the kidney would be like this. In the lower abdomen, what happens is it fails to ascend. It fails to ascend in a sense that due to any kind of obstruction, it was going upwards, and there was some kind of hindrance, and you cannot go up. So the hindrance was inferior mesenteric artery, which comes from the
Abdominal aorta.
Before, first of all, there are the two renal veins, renal arteries, and afterwards there would be the inferior mesenteric arteries, which will go to the inferior region of the mesenteries. But due to that artery present over there, there would be this would act as the hindrance between the kidneys, and kidneys would not be able to ascend upwards, and the gonads will come downwards, but they will not go upwards. So this is a very critical situation, that the kidney would function properly. So this has nothing to do with the kidney. The kidney would function normally. But what would be the drastic situation? This would be the associated with that of the hydronephritis. Hydronephritis, how it can lead to that of the increased hydro means water. Nephrons is the nephron which is present inside that of the kidney. By the way, how many nephrons we have got in one kidney?
1.2.
1.2 or 1.1 million nephrons in one or two kidneys, or both, or one kidney?
One kidney.
In one kidney we have got the
2.4 in one.
No, 2.4 would be in the two kidneys, 1.2 would be in the one kidney. So I'm happy to hear that you people know about that. So hydroamnios, this would be due to several reasons. You see that it could be due to the utropelvic. For example, here is the obstruction, utropelvic obstruction. If there is the utropelvic obstruction, or there would be the renal stones, if the renal stones are there, so you cannot properly urinate over there. Or it could be the congenital defects of the trisomy trisomy could also be the cause, which would be the trisomy 13, which would be the trisomy 21, which would be trisomy 18. Oh, by the way, trisomy 21 is the syndrome. Down syndrome. Okay. Then what is the trisomy 31 called as? Trisomy 31 would be called as the Patau syndrome, and trisomy 18 would be called as the Edwards syndrome. So we have also discussed in the non-disjunction lecture, so you can go and watch that series. So this is one thing, that the utropelvic obstruction will also lead to the hydronephrosis. So there will be increased water, and this is the very critical situation for the baby. So you must have to avoid that. You must be like here you can, how can you now place this kidney towards the its proper region, like before the birth, if it is not done by the God Almighty. So how this is a very critical thing, that you can place that kidneys towards the normal positioning. So this was one thing which we had to face in our clinical or practical lives. Now, second is the renal agenesis. Renal agenesis you might have heard so many times. Renal agenesis we studied in the pathology, general pathology lecture. I told you that in which of the growth adaptations this is an example of growth adaptation. Aplasia, exactly. So this is an example of the aplasia which we were discussing in the growth adaptations. So renal agenesis could be unilateral or bilateral. Unilateral means that you have got one of the kidneys absent. One of the kidney, which is the solitary kidneys, we can also call this disease as the congenital solitary unilateral kidney. Functioning kidney, which is the one kidney absent in that of the abdominal region. So this, how it will be presenting, how it will be the clinical presentation. So let us see it. There would be the thing that hypertrophy. There will be the hypertrophy of one kidney. So if any machine or if any of the organ you provide the workload, very increased workload on that. So if the workload is very increased, this will lead to the hypertrophy. Of course, this has no other words to do that. For how long your one kidney can work. So one kidney will workload will be that much increased that it will lead to the hypertrophy. And second is hyperfiltration. Okay, hyperfiltration means that there would be the increased filtration. How there would be the increased filtration? That for example, you have got the 5 liters of blood inside of your body, and 20% will go into that of the kidney, and the whole that 20% would be filtered by only one kidney. So your body is dependent on just one kidney. So there would be hyperfiltration. By the time it can work for the 10 years, 20 years, or the 30 years, by time you have to realize that this will lead to the renal failure. Because the bi kidneys, like the two kidneys, they were functioning. This is the normal thing that they would function, but at last there is the time that they will degenerate, that they will say, okay, now it's time for the rest now. So by this way, if you have got one kidney, so how can you take the work from that much little organ? 300 grams is the like normal weight of the kidney. So it depends upon the person to person. I don't think that even my kidney is 300 grams and some other person is also 300 grams. It just depends upon the person to person. So how can that 300 gram organ work that much? So once it has started working, it has to get an end. So it will hyperfiltrate and it will eventually lead to the renal failure. This is one thing. So what about the bilateral kidney? Bilateral, like if you don't have both of the kidneys, so the baby cannot survive. But during the pregnancy, you can see the oligohydramnions. Okay. Oligohydramnions and the polyhydramnions and the hydramnions. Hydramnions is the normal amniotic fluid present in that of the during the gestation period. Oligo means decrease and poly means increase. So what is the normal hydramniotic fluid? Any guesses? No? Okay. Let me tell you. This is, if it is less than 5 to 6 mole per deciliter. So it will be called as the oligohydramnions. If it is 3 to 4, this is the moderate thing. But if it is if it is even like 5 to 6 is a normal thing. But if it is even less than that, this will lead to the oligohydramnions. And you can see, and you can just check in that of the gestational period. So this is one thing, and you can see the flat faces. The kid will come with that of the flat faces. There would be the lower ears, and there would be this. You will be looking at the children, and it would be presenting as a stabbed person. Or you can see the very flat face, the broad nose you will see, or the Potter sequence you can say. Potter sequence we are going to discuss in just a few minutes. But here the bilateral kidney, the bilateral agenesis would be presenting the oligohydramnions along with the flat faces, the lower ears, and twisted skin. So this is the clinical.
What's like how it affect the physical appearance of a baby?
Okay, you see that everything, the kidney has very important functions to perform. Like the most important organ inside our body is the kidney. It has to filter, it has to provide the metabolic waste, it has to remove the metabolic waste, it also has to like regulate the electrolytes, it has to keep the balance of the water, of the toxic materials, and each and everything, like very important. Blood pressure, it is also maintained by the kidney, which will study in that of the physiology. So then you will get to know that the kidney has how much important function in our body. And if your kidneys are not working, so what about the metabolic waste? What about the water presentation? Like what is the amount of the water inside that of the kidney? So this will affect like formation of the RBCs, and even the blood is related with that of the kidney. So everything is related with that of the kidney. So how you can say that this will not affect the physical appearance of the baby, or the if you won't drink water, but it still affects our physical appearance. You will look pale, you will have like yellowish skin, and someone will ask like, either you are not drinking water. So water is just a normal thing for us, but still we can say that this affects our physical appearance. So kidney, which is the regulator of the whole things, like a very important vital organ. So if it is not working, how can the baby or the person be normal? Okay, you get that? Okay, now next move on, that there would be the congenital defects, and there's so many things later on we will study in the pathology. But still, this was the renal agenesis. Now we are going to discuss about the dysplastic kidney. Okay, dysplastic kidney. What do you think about the plastic? After here we can say this lining, which is going in this way. There is the omphalo celiac duct. Okay, and also there is another duct going, which is the allantois. Okay, what happens is it will grow in the both fashion, like it will go upwards and downwards. It will go upwards and will revert back, and in the like in the caudal region. Caudal means the tail region. You see, this is the caudal region. So this is the caudal region, this is the head region. Here would be up sac-like structures form over here, which we call as the cloaca. Okay, and upside there would be a little outpouching, which is the liver primordium. Like you can see that liver primordium. I'm very bad at the spellings, but still, liver M. So liver primordium means that further on it will go and form the liver over there. So this is the formation of the liver, which we will discuss in further lectures. But here today the lecture, which is about the renal system. So how it is formed. Let's move on to that. Here you can see that after the third week, like in the start of the fourth week, there would be a uterine bud formed over here. And attached with the uterine bud, there is also a cauliflower-like structure, and it will be called as the mesenchyme. Let's just say about it. Okay, so what would happen that afterwards from here there would be the formation of kidney. Before going into that detail, let me show you here what is the big perspective of this thing. There is also the formation of the pronephrons and the nephrogenic ducts. So you see, these are the nephrogenic ducts. How the pronephrons are formed. You see, here is the formation of the pronephrons. And here you can see the cloaca. It will be same on that side, which is the pronephrons here. Pronephrons. Pro means previous one. Okay, so in the 4th week up till the some of the days, like we can say 4th week it starts, and up till the 1st trimester it provides it functions as the kidney. It functions as the temporary kidney. So as it moves on in the 5th week or the 6th week, it starts degenerating. It starts degenerating in a sense that it will degenerate itself, because it has nothing to do with that of the renal system now, because now we have been developing in an advanced stage. Just likewise, you have got the earthworm. Okay, earthworm moves in a way, it moves its body and it goes along with that of its whole body. It drags itself, but the other remains of the caudal region of that earthworm will not remain in that region. So just like the earthworm, just think that this is the earthworm and it moves into the caudal region. Caudal region means to that of the tail region, from head to that of the tail region. So pronephrons will be formed, nephrogenic cord will be here in this region, and there would be the pronephrons here. After some time you will see that the pronephrons will start degenerating at the 4th week. At the 4th week, when we do the ultrasound, so we can see this thing that they have been starting degenerating. Afterwards, there would be here. Second thing, there was the degenerated nephrons, which was the pronephrons. Second thing is the whole things which are present in the nephrogenic region or the duct. We can say this is the mesonephron. So mesonephron, up till the 1st trimester of the gestation, it acts as the kidney for the fetus, or you can say during that of the gestation period, it acts as the kidney for the baby. After that, the 1st trimester, there would be the metanephron. So what the metanephron does it? Metanephron is the permanent kidney which we were trying to make from the very first day. From the zygote we were trying to make the kidney. This is the metanephron. Up till the birth, it will remain developing and you can see that it will remain alive for the 80 years, or you can say for the 90 or the 100 years, as the zygote can live for that much period. So up till the birth it will form that. So what is the function of these buds, uterine buds? This is the caudal region, this region. Together it will form the proper kidney which I was talking about. So this is the uterine bud and here is the mesenchyma. So mesenchyma is present over there, uterine bud is formed. From here, the uterine bud, there would be the ureter is formed over there, and the primordiums of the calyx, they are also present over the minor calyx, the major calyx, the pelvis. These are all present formed by this region. Okay, so this was the formation of the kidney which we were trying from the very start to make that kidney. So this ends our thing about how the kidney is formed. There are some pathologies, there are some like congenital defects, there are some inherited defects within that of the kidney, formation of the kidney, and the babies are suspected to that. What are those? We will discuss in a bit detail. Firstly, if there is if there is something abnormal in the uterine tube and also the metanephritic duct, we can say if they are not properly formed, if they have got some kind of abnormality in it, in those both conditions there would be the not the proper development of the kidney or the renal system. The first example would be the horseshoe kidney, which is just looks like the horseshoe. What is the physiology or what is the pathology in that, we are going to discuss in that. So what are the congenital defects? Let me remove some area so that so you see, like if the uterine bud and the mesenchyme both fails to form the proper proper structures, this will lead to the diseases. This will lead to the congenital defects. This is the mesenchyme of what? Nephron. Because this is the same. Don't think that this is another species from another world. This is the same metanephron which is the part of the nephrogenic duct. Okay, it just come out of the nephrogenic duct. So this is one thing. So if both of these fails to develop, one this and this uterine bud, you see this is the uterine bud and this cauliflower like shape, like lettuce like shape, this is the metanephritic mesenchyme. If this fails to develop properly, this will lead to the congenital defects. And there are 6 main defects which we usually see in our like clinical lives. So there are many defects, but mainly there are the 6. So first one we are going to discuss is the horseshoe kidney. Horseshoe kidney, as the name defines, that this kidney would be presenting itself as there is the horseshoe. So you see horseshoes, you have seen like this shape. So you can revert it in this shape. So horseshoe is just like this. So how the kidney would be presenting, it is the malfunction in the kidney would be functioning properly, but there would be the genetic defect, like there would be the congenital defect in the development. Normally what happens is that the kidneys are formed in the lower abdomen and the gonads are formed in the upper abdomen. But what happens, like there is during the fetal development, the kidneys goes upside and the gonads go downside. So downwards during that development, the kidneys could not go in the upper abdomen like into its proper region. How it is presented, for example, you see here are the gonads present and here are the kidneys, and this is the, for example, just think that this is the pelvic region. So during the fetal development, these kidneys has to go upside and these gonads has to come downwards. Gonads will come to its normal position, but in this congenital defect, what would happen, that the kidney would not be able to go upwards to its normal position due to one thing, and it will remain in the pelvic region or the lower abdomen. That, for example, you see here is the aorta, abdominal aorta, and here you see there is the renal. There would be the renal arteries. We discussed in the anatomy. Afterwards, we will also discuss in. So this is the renal. This is the abdominal aorta, and this is the renal arteries, which are connecting this way. But due to some reasons, there is the inferior mesenteric artery. Inferior mesenteric artery will not. It is present. It comes out from the abdominal aorta. In the abdominal aorta, there is the inferior mesenteric artery and it got trapped. These both kidneys got trapped in behind the inferior mesenteric artery. For example, we can